So again, thank you, Dr. Virani, Dr. Nathan, for really inviting me to this conference. This is a lot of good work, and I was mentioning it earlier. The kind of partnership we have between foundations as well as academia is really the way to go when you don't have as much NIH funding or funding in general to actually study a group. Now, what I will talk about is a little bit on heterogeneity of risk. All of you who attended this conference now for 2 days probably understand that just using the word Asians is not enough. There is a reason why we use the term South Asians, and then even among South Asians, there is heterogeneity of risk, which I will try to show here. And then I'll spend a little bit of time talking about the use of imaging. It's very heartening to see that a lot of data that I will use, a lot of authors were either sitting in this room or they're still sitting in this room. So it's wonderful to see that. And that means that the organizers have done a terrific job of actually getting most people who work in this space into this conference. So with that, I'll start. These are my sources of research support, some of which does support South Asian research that we are doing right now and hopefully will continue to do in the future. So these are really the 3 or 4 points I wanted to talk about. Talk about Asians and South Asians. We've heard enough now that we need to stop looking at just Asians in the United States. Goes without saying at this conference. Show you some data related to that. South Asians in the United States, give you some numbers related to the census from 2020. So when you talk to others, you have some denominators in terms of what kind of numbers we are looking at for South Asians. We'll talk about heterogeneity of risk among Asians. The last talk we discussed some of that. I'll show you some more data related to that, and maybe try to hit on a few points outside of what has already been done. I'll talk about imaging markers of atherosclerosis in South Asians compared with other ethnic groups. And then really, where does it all lead us? So, first of all, you all know what South Asia is. It's about a quarter of the population right now. Now, these are the numbers that I think are important for us as South Asians living in the United States when we look at the 2020 census, which really was recently released. So we have about 24 million who are Asians, who call themselves Asians. But if you look at, there's been 39% increase compared to the census in 20. So it's one of the fastest growing actually groups in the United States is Asians. Out of that, we have the largest group, which is Chinese. Indians are pretty much catching up. Then we have Filipinos. We'll look at some of the data related to that. And then you have Pakistanis, Bangladeshis, and Nepalis that I've put down since we're talking about South Asians. So again, amongst the South Asians in US, you're looking at a lot of Indians. And then I'll show you some data that even amongst these 3 large groups of South Asians, Indians, Pakistanis, and Bangladeshis, there is actually difference in terms of risk, which is pretty much, we're just at the tip of that iceberg. We really do not know much about it, but there are some things that we should keep in mind. Now, this is very, study from 2019 that's quite highly cited, that the risk of whether you look at total diabetes, diagnosed diabetes, undiagnosed diabetes, it's high in South Asians, even when you adjust for age and sex. I'm not going to spend too much time on this. This was just to set up the stage. At this point, I'm pretty sure you all know that the risk of diabetes is high. What I want to focus on is whenever we look at a risk factor in preventive medicine, it's not just the risk associated with that risk factor, it's also the number of years you live with that risk factor. So I know we have a lot of people from the community here. The other thing about diabetes that you should remember is that it's not just the prevalence of diabetes being high. We get affected by diabetes at a much younger age, right? This chart we have here, look at the age at the time of diabetes that was diagnosed, and that's much lower in South Asians compared to other groups as well. So remember, when we talk about a risk factor, the first question we ask is prevalence. But it also matters when you develop that particular disease. So even when diabetes may be very well controlled, just living with a disease for a very long time is a problem. The second thing that is very important and that has come out quite significantly is gestational diabetes, right? So gestational diabetes, if you look at US right now, is about 6% of all the pregnancies. And in South Asia currently, gestational diabetes is about 17% of the pregnancy. So it's about 3 times higher. Now I say this for various reasons. Some of those were discussed earlier as well. There is risk for the mom. When a woman develops gestational diabetes, we know that that increases their risk of developing frank diabetes as well as cardiovascular disease. And all of that cardiovascular disease risk cannot be explained by just diabetes. So that's one factor. But the other aspect of that is what we know, that the risk to the offspring, right? So when you're looking at gestational diabetes, I would urge you to look at not just that woman who's sitting in front of you and their future risk of diabetes and cardiovascular disease, but also the risk to the offspring. So those were 2 things I wanted to add. First is premature diabetes, and I'll show you some other data for other risk factors as well. But then when you're looking at gestational diabetes, also think of the offspring. There are quite a few studies happening now. In fact, I have just read somebody's PhD thesis where they looked at carotid INT in teenagers. And even there you see a difference by maternal history of gestational diabetes. So very early on, we start seeing some subclinical atherosclerosis. So that is what we just talked about. The other aspect is hypertension. Now we know that when you look at the disaggregated data amongst Asians, Filipinos have the highest prevalence of hypertension, right? South Asians don't have a very high prevalence of hypertension, but if you look at Asian Indians, again, that's the largest group. When you look at, this is again from NHIS, one of the data sets that Dr. Lapin also talked about in her talk. If you look at premature hypertension, it's the highest among Asian Indians as well. So again, overall prevalence may be low for hypertension, but those who develop hypertension develop it at an early age. So the number of years you have to live with that is high. So overall attributable risk may actually be the same. Yes, you have fewer people with hypertension, but they end up living much longer with hypertension. So you have a higher risk of developing complications. So again, what I wanted to emphasize with these slides is don't just focus on prevalence either. Prevalence is a good start, but also look at when people are developing those risk factors. And one of the things that's noticed for diabetes, hypertension, heart disease is that we tend to develop these much, much earlier. So that's that part. Now again, these are just the adjusted analyses where you adjust for age, sex, a lot of other things, and you still see that South Asians continue to have a high risk of premature hypertension. These are data from Kaiser, I believe, where they followed patients for 10 years. And again, what you see is that premature cardiovascular disease is very high in South Asians. I'm pretty sure this has been shown at least once, if not twice already in the conference, so I'm gonna skip through this. This was just shown. I love this paper. And again, the 2 things are that the rates are perhaps increasing in men and they have plateaued in women. In fact, non-Hispanic women are now a little bit below Asian or rather South Asian women. And then the other thing is that amongst Asians, we have the highest risk of having cardiovascular disease related death. So that's something we need to work on. We should not forget that a lot of progress has been made. Of course, we have to look at this first. The rates have come down, but this is interesting in terms of what is driving this, especially amongst men. We need to definitely study that more. Now, these are data, again, from NHIS. These are small data sets. You really don't get as much granular data, but here again, you see when you are looking at premature cardiovascular disease, so or rather this is premature CHD, so we only looked at heart disease. What you see with South Asians is, or again Asian Indians is how they say it. If you look at premature CHD using this definition, you look at prevalence of CHD at age less than 50 or less than 40, If you look at all the ethnic groups in the US, one of the highest prevalence. Now, what is driving that? We can talk about that. I think that's something that's been discussed ad nauseum. But I just want to bring this up, that quite a bit of this is premature disease. The reason I wanted to show you these 3 slides, one for diabetes, one for hypertension, one for CHD, I knew this was all going to be shown. But the message here I have for you is that if we start working on South Asians when they are in their 30s and 40s, we might have lost the boat. Where we really need to go with these interventions is our young kids. That's where the action needs to happen. Because remember, atherosclerosis can be documented even in teenagers, right? Whether they have a lot of risk factors or not, we can document that. So the age when we really need to work on in our community, and that holds true for other communities as well, by the way, is just that we don't have a lot of time to make a difference. And that is where the concept of primordial prevention comes in, right? Primary prevention is when somebody develops a risk factor, you treat them so they do not develop their first heart attack or stroke, or in terms of cancer, it would be first cancer. Primordial prevention is how do we prevent our population from developing a risk factor, i.e. they don't develop hypertension, don't develop diabetes. What can we do for that? And if we have to make a dent there, we really need to go even further down, look at our kids and school-going kids, look at the teenagers, look at people in their 20s, and those are the folks who are most difficult to target, but that's really where action should happen, whether it's work that's done by foundations or whether that's work done by academia. Now, that was of course everybody together treated as same when it comes to South Asians, but we know, based on some data that's coming out now, that even all South Asians are not created equal. There is heterogeneity of risk. How much of that is related to cultural practices, diet, differences in physical activity, geography? I'll show you some data related to that as well. Versus religiosity, we don't know. But we need to understand that right now we are just scraping it whereby we're able to say, yes, South Asians have this or that. But even among South Asians, there's a lot of heterogeneity, and it is not something that is unexpected. This slide is difficult to read, so try not to read it. You'll have a headache, especially after having your meal. Again, the important thing here is that these are data from the 2020 census. And I'm going to highlight some of the groups here. So if you look at the Indians residing in US, look at their income. It's much, much higher compared to other South Asians living in this country, right? When you compare them to Pakistanis, Bangladeshis, Nepalis, right? Look at education as well. Look at home ownership rates as well. The reason I mention this is that, and there has been so much said on this, that when we talk about NCDs, NCDs are very closely tied to social determinants of health. So if we are going to be looking at policy level implications, yes, we'll do well by diagnosing disease early, doing interventions early, but a lot of this will need to be taken into account as well. Trust me, if you ask a Bangladeshi working at a C-store to go walk 30 minutes every day, good luck, because they are working 14 hours. They are not your Pakistanis or Indians who are basically on the West Coast working in an IT company. These guys work 14 hours, 16 hours, they just go, sleep, and come back, and they eat whatever they can get their hands onto. You know, we see quite a few of them in Texas when you go to these convenience stores, these gas stations, and you talk to them and you realize that this is what it is. A lot of them are perhaps not even captured because they have permanent settlement issues. They don't even have work visas, right? So that is where the real disease is in South Asians. Yes, we have disease in the educated South Asians as well. But if we have to really be very fair, we should go and look at all of those groups that we are talking about here. So that's one thing. That's something that might be driving it. The other aspect of this is that if you look at the South Asian community, overall they are in urban centers, but those urban centers may also vary based on the east or the west, north or the south. So they are going to, as they assimilate in these geographies, if you have a lot more disease in the south of US compared to north or northeast or west coast, The same phenomena is going to happen with South Asians as well, depending on where they live. So this geographic heterogeneity in terms of where they reside will perhaps be driving some of this difference that we will see in the next few years as well. This is a study from Spain done by one of my very good colleagues who's moved back to Spain now, used to live in US. And there you will see this is very good quality data, and some of this stuff is highlighted for you in terms of when you look at the burden of diabetes, hypertension, heart disease, heart failure. You will notice that it is very heterogeneous, even among South Asians, right? You will notice that for a lot of these Pakistanis and especially Bangladeshis have quite a lot of burden, right? And when you look at this, you realize that the future research agenda for those of us who are working with the South Asian community will need to expand a little bit and make sure that we get all the South Asian groups. This of course does not even include all the South Asian groups, but even within this very tightly knit group that we would think would have similar risk factor profile, look at the differences that we have here. And these are the same things that have been seen in UK Biobank. You probably saw this in the context of the current risk stratification algorithms not working really well when it comes to South Asians. All of them underestimate the risk. But even in this study, this is perhaps a very large data set of South Asians. What I want you to look at is look at the risk in terms of Indians, Pakistanis, Bangladeshis. There is clear heterogeneity in terms of risk. My question is, do we even understand what is driving it? In fact, I am not even sure we have fully learned that how much of this difference is real. We are seeing this story come out, but what is the absolute increase in risk for a Bangladeshi versus a Pakistani versus an Indian versus somebody coming from Nepal? We just don't know that. And then what is driving that? And then do we need to have our interventions that are sensitive to each of these groups as well? So there's a lot that we need to learn in these groups, and that's really where things are moving. This is some of the work that has been done from Masala, and of course, you know, they're all sitting here, and it's some amazing work. I just put this up there to show you that even when, again, this is calculating heart failure risk, this is not actual heart failure, which is, of course, driven by presence of risk factors. But when you look at, you know, born in other South Asian countries versus India, there is heterogeneity in terms of risk of future heart failure events. Remember, these risks were not developed in South Asian, so take it with a grain of salt. But just for a point of discussion, there is heterogeneity even in terms of calculating heart failure risk. This is data again from the Masala study. When you look at north-south differences, right, for people who came from northern versus southern parts of India, and you compare them against each other as well as Pakistanis who are in Masala, despite small numbers, you see that there are differences in terms of risk factors. Hypertension perhaps more prevalent in those who trace their origins to North India versus dyslipidemia, perhaps higher in those who are coming from South India and from Pakistan, even when you adjust for a lot of baseline differences. So again, how much of this is urban, rural versus cultural practices in terms of diet, physical activity? A lot of work that we need to do, and then a lot of that work needs to be incorporated into the interventions that come out of that. So now let's switch gears and talk a little bit about imaging and markers of subclinical, and I would say rather clinical atherosclerosis in South Asians as well. Again, Masala study, amazing work that's been done. This is looking at coronary calcium scores, which is I would say pretty strong marker of subclinical atherosclerosis. The US guidelines have also elevated the recommendations from what used to be a 2B recommendation, something that you may consider, to something that can be considered as a 2A recommendation now in risk stratification. And what you'll notice here is that when you look at South Asian men in Masala study, their calcium scores track really well with whites who have much higher calcium scores than other ethnic groups. So that's one thing that is extremely interesting to note here. There is a decent amount of subclinical atherosclerosis. In women, it seems to be the same till you get to this age of 70, and then it shoots up. Of course, the sample size here is small, so take it with a grain of salt. But definitely for men, you see this pattern, which again meets the eyeball test. You would expect that if a lot of events in this group happens early on, then there is a lot of subclinical atherosclerosis as well. So yes, we can look at subclinical atherosclerosis in this group. The other aspect of this is disaggregating the coronary calcium score into calcium density versus calcium volume being the real driver of events based on recent studies. And what you will notice here is that a lot of it is actually driven by BMI, hypertension, as well as diabetes and insulin resistance. Perhaps we can control subclinical atherosclerosis by working on these traditional risk factors that meet the eyeball test. So that was subclinical atherosclerosis. What happens when we see patients with actual coronary artery disease and people are undergoing coronary angiograms? This is from Penn Medicine. This is a study where they took South Asians coming for coronary angiogram and they matched them to non-Hispanic whites and looked at how does the coronary angiogram look like. Now, small sample size, but food for thought. What they saw here was that if you look at the number of diseased vessels, right, it's much higher in South Asians, the number of diseased vessels compared to non-Hispanic whites. Proximal disease was much more common in South Asians as well. And when you normalize to BMI, South Asians had much narrower lumen compared to non-Hispanic whites as well, which is telling you that there is a lot of atherosclerosis happening in the artery wall. So even when we look at actual atherosclerosis using an angiogram, which is a traditional gold standard, these are of course people who are coming to a facility with some symptoms that prompts an angiogram. We see that there are differences in terms of the severity of coronary artery disease as well. So again, if I have to just conclude, again, most ASCVD risk factors are more prevalent in South Asians compared to other Asians. I'm glad that now the CDC, NHIS, all these data sets we are able to at least disaggregate and get a category of South Asians or Asian Indians. Of course, we need more data related to that. Most ASCVD risk factors, and ASCVD itself is more premature in South Asians, and I really want that to be an important message that you all take home when you go home and talk to your kids. ASCVD risk is heterogeneous across various South Asian subgroups and among groups within each country. That's where I believe a lot of work will continue to happen. Epidemiology will continue to inform us as far as that piece is concerned. Subclinical atherosclerosis may be more prevalent among South Asian individuals compared with other ethnic groups. There is therefore an ongoing need to further disaggregate ASCVD risk among various subgroups of Asians and subgroups of South Asian individuals. So thank you for your time, and thanks again for the invitation.